Alright, so in our previous video we discussed preload, afterload, and contractility, and so we're going to discuss this in a little more detail next. Okay, so preload we talked about as the filling of the heart. What are we filling the right atrium with, which will eventually go to the right ventricle, lungs, left atrium, left ventricle, and then out to the systemic circulation. So preload is filling. Okay, so what is the heart filled with? That's blood. And blood has two components. We have the plasma component and the cellular component. The cellular component being the red blood cells, white blood cells. Plasma component is basically the fluid. So fluid, and this component is made out of the water component. So if we want to increase preload, we need to increase this component here. So how do we increase the plasma component? Well, that's easy. You can give someone IV fluids or oral fluids or any sort of fluids. You can increase the preload. So to increase preload, we can give fluids. You can give packed red blood cells, which would be the cellular component. You can give whole blood, which is everything. So that's how we increase preload. What decreases preload? Well, anything that takes away fluid. So hemorrhage. So if you're bleeding out, that'll decrease preload. Dehydration. That will decrease preload as well. And so when we think about preload, we should simply think about what are we giving? What does the heart have to work with to pump? So even if everything else is in order, contractility is good, afterload is low, but if the heart doesn't have anything to pump with, then it's not going to be able to sustain a good blood pressure, right? So in these cases, the heart has a harder time maintaining a blood pressure, right? In hemorrhage, you can have hypotension because of that, okay? And how do we treat hypotension? We always give fluids, right? Because we want to make sure that we take this out of play when we want to treat someone's hypotension. So that's preload. Next, let's talk about contractility. So contractility is going to be how hard the heart is pumping, okay? And so this is a little bit more elusive to think about. So how hard it's pumping, or the oomph, or the strength of contraction. And so what determines contractility? Well, one of the receptors that we find on the heart are the beta receptors. Okay? To find the beta receptors, and if we stimulate these beta receptors, then we can increase both ionotropy and chronotropy. And these are terms that you have to know. So chronotropy refers to increases or decreases in the heart rate, okay? So if something's a positive chronotrope, that increases the heart rate. It's a negative chronotrope, that decreases the heart rate. Ionotropy refers to contractility. And so we have drugs that we can give that are positive ionotropes, okay, to increase the contractility. And so one of those classic drugs, positive ionotrope, is digoxin. So you can give digoxin, that increases ionotropy. You can give a beta agonist, and that would also increase contractility. Okay, and what are our beta agonists that we can give? Dobutamine, which is a beta 1 specific agonist. We can give something called isoproterenol, and that's going to be our mixed beta 1, beta 2. This isn't a lecture on pharmacology, but I remember iso means same, so it's both same on beta 1 and beta 2. Okay, so that's contractility. Now let's think about afterload. So afterload is what the heart has to pump against, okay? And so simply, the way I think about it is, what is the pressure the heart's pumping against? Well, that's the blood pressure, okay? And now you're probably thinking, maybe, wait a second, you're telling me that preload, afterload, contractility determines stroke volume, and all this stuff determines blood pressure. Now you're telling me afterload is blood pressure. Well, so this isn't a good technical definition, but it's an easy way for me to remember, and for when I'm answering test questions, what the heck afterload is. So afterload is basically whatever the heart has to pump against, and what it most commonly has to pump against is a blood pressure. So what increases afterload? Well, anything that's going to increase the blood pressure is going to increase afterload. So some of the things that we talk about would be hand grip, So if you're gripping your hands, it's harder for the blood to flow through your hands, so that's going to increase blood pressure, or that's going to increase the blood pressure, and that's going to increase your afterload. Squatting, you're compressing all the vessels in your legs, and that's going to make it harder for the blood to flow through them, and that'll also increase afterload. Squatting also increases preload too, right? So you compress all the veins, and that all the blood in the veins and end up going back into the right atrium. Okay. What is a classic condition that has a massive decrease in afterload? So a massive decrease in afterload, the one condition you must know about is septic shock. Okay? So in septic shock, you have bacteria and you have the immune response, and together they release a ton of cytokines, which causes massive vasodilation. Okay? Massive vasodilation. Okay? And you get hypotensive because of the vasodilation, because you significantly decreased your total peripheral resistance, but you also significantly decrease your afterload. So that way that we treat septic shock is to give pressors. First thing you do is give fluids, because you want to make sure you take away preload out of the equation. But then you also have to give pressors, usually norepinephrine, to increase the total peripheral resistance here. Okay? And once this total peripheral resistance is increased, then you can maintain a healthy blood pressure. So remember, septic shock is a massive decrease in afterload.